Hi everyone, my name is Muhammad Ali. I'm Associate Professor of Neurosurgery at Mansoura University of Egypt, and I'm going to talk about the Intercollegiate FRCS examination um, guide for Viva and the clinical examination. So my outline is I will talk about the format of the examinations, the curriculum, how to study for each vignet, understanding major concepts, important references, and some case scenarios. Um, so as we all know, the exam format for the FRCS examination is oral and clinical. For the oral, you have three stations: the investigation of neurosurgical case, non-operative and basic science, and operative and surgical anatomy. Each of these stations have 6 cases. Each case have 5 minutes, and each case will have 2 markings. For the clinical, you will have 2 long cases, each 15 minutes, and each has 12 markings, and 4 short cases, each 7 minutes and 6 markings. So overall, you will have 84 markings. Each marking is from 4 to 8. The passing mark is 6. So the overall passing mark is 504. If you look at the evaluation of the markings this is from the guidelines of the exam, you will find that they put a lot of emphasis on the quality of response, confidence, judgment, high order thinking, justifications, familiarity with literature, and evidence-based approach. So I encourage you to read this form to understand that the examiners are going to evaluate your response in many ways, because a lot of people usually say, okay, we did the right answer. So if you want, so the passing mark is 6, but if you want to get extra marks, you should have clear logical response, you should have high order thinking, and this will help you to compensate for a missing of some case scenarios. So when you look at the relative weight for the clinical and oral, you will notice that the long cases represent 29% of the total markings, and short cases also 29%. So each oral stations represent around 14%. So each long case represent about 40% compared to for the oral, each clinical case represent about 2.5%. I think you should consider the relative weights for long versus short cases for oral exam when planning your strategy for the exam, because you cannot miss any of the long cases or short cases if to get the passing mark. In contrast, you can miss few oral case scenarios and you still can pass the exam. So there's very comprehensive curriculum from the examination committee, around 90 pages, which is very complicated. Going through this curriculum and past examinations, I have working on more simple curriculum, which is based on each station, which make studying easier. For example, for the oral and the investigations, usually ask you about the investigation for neurosurgical cases, including brain tumors, infections, spine, vascular, pediatrics, head injury. And for example, for neuroradiology, high yield is advanced MRI imaging for gliomas, for example, distinctions between abscess and gliomas, functional MRI, DTI for preoperative mapping of low-grade glioma, vascular imaging, including CTA and DSA for vascular malformations or aneurysm, electrophysiological studies will include will usually include like nerve conduction velocity and EMG for carpal tunnel. Laboratory tests such as tumor markers for binary region tumors, endocrinological evaluation of supracellular tumors, CSF tests for shunt infections or meningitis, microbiological tests for infection, including spine TB, brain abscess, spondylodiscitis, ICP monitoring for head injury, metastatic workup for brain and spinal metastasis. This is not a comprehensive list, but at least when you, in my opinion, when you uh, make your curriculum based on each station, so you know that you will be asked about the investigations, and again you will be asked about the investigations of brain tumors. You will find that you have few um, good scenarios, and if you are asked about the microbiological tests, you have 3 4 different scenarios. That way you can narrow the uh, probabilities of the examination and make it easier to capture the whole spectrum of the exam. For the oral non-operative, they usually focus on critical non-operative subjects, like, for example, neurocritical care, including VTE management, reversal of coagulopathy, electrolytes like hyponatremia, medical management of head injury, spinal cord injury, vasospasm, low back pain, chemotherapy for common brain tumors, and role of genetics like glioblastoma, GBM, primary CNS lymphoma, multidisciplinary management of trigeminal neuralgia, vestibular schwannoma, and neurophysiology and neuropharmacology, including pain pathways, spasticity, are also very common. So for the operative, you will be asked about common degenerative disorders like ACDF, lumbar decompression, posterior-cervical laminectomy, spinal tumors, thoracolumbar fixations, basic cranial approach for common brain tumors, especially intraventricular tumors and meningioma, basic pediatric procedure like endoscopic third ventriculostomy, VP shunt, treatment of arachnoid cyst, basic principles of AVM resections or aneurysm clipping, functional like DPS, microvascular decompression. So the clinical long cases usually involve long and relatively complex scenario like carry malformations, rheumatoid partners, supracellular lesions, cervical myelopathy, neurocutaneous syndromes, vestibular schwannoma, binary region tumor. The clinical short cases are usually shorter, less complicated scenarios like thoracic disc syringomyelia, ulnar neuropathy, carpal tunnel syndrome, focused examination for gait, for example, normal pressure hydrocephalus or Parkinson's disease, proptosis, Parinode syndrome, focused history for epilepsy, for neurogenic claudications or trigeminal neuralgia, pediatric cases like meningomyelocele or craniosynostosis. So the second question is how much and how you will examine for each of these clinical scenarios. Most of the examinations will focus on the clinical decisions making. You are less likely to be asked about theoretical informations which are not directly involved in what we call the decision tree or the decision analysis. For example, usually the first decision you make is how, which questions you are asked as a patient. And from that, based on the history, you decide the focused examination you will do, then the investigation plan, then finally you do the treatment decision. And another important aspect is counseling, important points in counseling and complication and their avoidance. So anything which is not going to fall into these questions is less likely to be asked. The examination is mainly clinical based. So I suggest you, my first advice, you should focus on case-based scenario. The way I used to study to the exam is I make a clinical scenario for each case and then go through the logical questions which is going to happen. They will give you an image, so they will ask you to interpret the image. Then they will ask you about your investigation plan, treatment decisions, and from there you would expect certain important questions based on your experience and on your studying. The second advice is this exam is at the level of day one consultant. So they don't expect you to be fellowship certified vascular or epilepsy surgeon. So they expect you to have the basic knowledge and CVT for level one day consultant. So you don't have to go very deep. It's very important to understand the major concept, the examination. I think this exam have some concepts, some certain areas which they ask, which is actually not very advanced, but they need you to prove that you understand these basic concepts for safety and decision making very clearly. If you are not understanding these concepts, you might study a lot, and that will be counterproductive, because if you study a lot, you will miss these concepts during the examination, and I see that happens with a lot of people. So it's important also to understand that the examination is going to ask you about your high order thinking, your decision making. They challenge you with unusual situation to see your judgment. It is not that they will give you the typical scenario and you will have the typical answer. Familiarity with the literature and evidence-based and able to justify your decisions, I think, is very important. And finally, I want you to remember that for each oral case, you will be, it is just 5 minutes. So you don't have to, if you told me that you study 20 pages for one clinical scenario, I think this is too much. I think if you can pinpoint the important questions, you will study smarter, you will study less, and you will pass the exam. Let's go through one scenario, which is for operative, about how to manage operative treatment of intramedullary tumors. So they usually will give you the images, which is in this case as MRI with contrast with serings and intramedullary tumor. They will ask you to interpret the images and make a differential diagnosis, which in that case includes astrocytoma, ependymoma, and hemangioblastoma. The investigations workup will probably include whole axis MRI with contrast to, because a lot of these lesions is associated with NF1 and F2 and might have associated intracranial lesions. They expect you to understand the basic anatomy. Preoperative planning is very important, and in such case to include electrophysiological monitoring and intraoperative ultrasound to localize the tumors. Most probably you will be asked about the basic concepts of intramedullary tumor, which is you should have nice plane of dissection between the tumor and cord to ensure the safety of resections, and you should start with debulking before you dissect the tumor of the cord. If you don't find that plane of dissections, you should just do a biopsy. Generally, the plane of dissection is more developed in ependymoma, much less in astrocytoma. They will ask you about the common complications and important complications, which in this case will be worsening of the neurological status, which can be avoided by using electrophysiological monitoring and microsurgical techniques. And you might be also asked about how you manage if the electrophysiological wave is disrupted. Another potential complication is iatrogenic instability, which can be avoided by laminoplasty. So another clinical scenario is the diagnostic approach for subarachnoid hemorrhage. Again, they will present the CT images with subarachnoid hemorrhage. They ask you about your interpretations, which should include the pattern of subarachnoid hemorrhage, whether it's aneurysmal versus, for example, perimesencephalic, if there's associated ICH, IVH, Fisher grading, and then they will ask you about your investigative approach, which probably would be CTA, and you should be able to justify why. CTA because it's less invasive and highly sensitive. And then, you might ask you about what if the patients have CTA negative in setting of typical subarachnoid hemorrhage pattern. Diagnosis of vasospasm, workup for vasospasm, including metabolic workup, CT, transcranial Doppler, and they finally will ask you about the management plan, endovascular versus open, will ask you about the level of evidence from ISAT study and the complications of treatment. So this is the level, this is the level the exam is going to start to test you. And remember that, for example, in a book like Handbook of Neurosurgery, you might find subarachnoid hemorrhage in 70 pages, which is kind of huge distraction. So let's go for another scenario, which is binary region tumor. 8 years child with 3 months history of progressive headache and gaze problems. Ask you about your investigation plan, which should include whole neural axis MRI with gadolinium, again to rule out drop metastasis. Then they will, or CT with contrast if the patient is presented acutely. Formal neurological, formal ophthalmological, and endocrinological evaluation is needed, particularly because synchronous supracellular lesion can cause endocrinological problems. So here's, if this is a long case, it will ask you about your history and physical examinations, and this should include very clear list, including increased intracranial pressure, Palinode syndrome, cerebellar signs, diabetes insipidus or visual field defect for synchronous supracellular lesions, drop metastasis, and others. And here you will notice that this list is little complicated. If you are not well prepared with your checklist for the history and physical examination, you will lose a lot of markings. And I think one of the biggest mistake people do is they don't focus on the clinical examinations and history, assuming that it is what we do every day. But in real life, I think this is a big source of missing points. And if if there is a real patient in the exam, you should be very well prepared because you have to do the exam in 2.5 minutes, which is very short. So you have to be practice the neurological examination, your checklist, and be able to do it quickly. So differential diagnosis is highly tested, and the reason is you have here diverse pathologies, including pineal parenchymal tumor, germ cell tumors, other tumors like meningiomas or tectal gliomas, and so you have very diverse group of pathologies which have different treatment. So germinoma can just have excellent response to radiotherapy. Malignant germ cell tumors need chemotherapy, radiotherapy followed by surgery. Pineal parenchymal tumor needs surgery followed by adjuvant therapy. So here, this is a very interesting area, and they would expect you to understand the diversity of pineal region tumors and their mode. So again, if you look at the algorithm, most of the questions you will be asked about pineal region tumors, which is restricted to the decision analysis or decision. Tumor markers are very high yield concept. You can be asked, especially in the investigation plan, and they would expect you to have a clear understanding of the role of tumor markers. So tumor markers are very important. They have very important diagnostic value because they can narrow the diagnosis for malignant germ cell tumors in combination with imaging. So if you look at the imaging with the tumor markers, you can pinpoint the malignant germ tumors, especially yolk sac tumor and choriocarcinoma. And why it is important? Because these tumors are highly vascular, and usually surgery have high risk of hemorrhage. So usually these tumors are treated by chemoradiotherapy, then surgery if they partially respond. So this is why tumor markers are very important, because they ensure, obviate the need of biopsy with the attendant risk and reduce the risk of hemorrhage which might be unnecessary. The other importance, it also tumor markers can be used to monitor the response to treatment and occult metastasis, and they might also have some prognostic importance. So here you can see they will ask you about the management plan, which is again we talk about that is very variable according to the pathology, which highlight the importance of tumor markers and imaging to be able to expect the pathology. Biopsies indicated if you cannot reach a clear diagnosis, and management of hydrocephalus is usually done by ATV rather than ventriculoperitoneal. So if the patients have hydrocephalus, this is a very high yield question. Also, you will be asked about the endoscopic procedure of CSF sampling, ETV, and biopsy. And here there will be few important questions, including whether you do biopsy first or ETV, how you will plan your beer hole, and what are the complications of ETV, and the anatomy of the floor of the third ventricle. So these are all very highly tested questions. And again, these are the questions most commonly asked. You don't have to have very extensive knowledge about the binary region tumor. You should understand the major concepts which is tested. So if you look at the important concepts, again, we talk about the idea of concepts. The concepts of Banyel tumors are the very characteristic clinical syndrome, including Barry Node syndrome, is very highly tested in the in the clinical exam. Differential diagnosis and wide variability of the pathologist is very highly tested. Tumor markers, endoscopic procedures are highly tested. And you see that, this is a very high yield. This is even um, um, long case. And if you understand these concepts, we get through that in 5 minutes. You don't have to study for 20 pages for binary region. So my advice for you for success of this exam, you should have your study plan balanced. I think one of the problems is when we study, we tend to focus on certain areas, which is everyone have different practice, different spectrum, and I think there is tendency to focus on what we are interested in, on what we are do every day, and there might be certain areas which we are not familiar or comfortable with. For example, a lot of people they don't do pediatric surgery. It happens with me, and I didn't focus on the pediatric surgery. You have to have very balanced way, and you have to consider the relative weight of clinical and oral in the exam. My second advice is don't study from textbook, focus on case-based books. Make your own case scenarios and imagine which questions are important. These are most probably you will be tested in the exam. Focus on important concept. Try to understand why they are asking you about this topic and what important concepts. And you should be, even when you have important concepts, you should be able to express this concept clearly. For example, we talk about tumor markers. When you ask it about the tumor marker, you should show that you understand this concept very clearly and how it will affect the patient's management. We talk about intramedullary tumor, the resectability of the tumor, and how important it is to have a good plane of dissection. This is an important concept, because if you don't understand this concept, the most probably you will injure a patient with intramedullary tumors. You should understand that the mark you get is dependent on the quality of your response. So it is not about you get the right answer or the wrong answer. Even if you get the right answer, the way you answer, your confidence, how you are going to present your answer, how you are going to justify your answer, you are going to cite the literature, make the difference between a passing mark, which is 6 or 8. This is very important, because whatever you do, you will miss some stations, and you need to get extra marks by having high quality response to compensate for that. Uh, my last advice is high order thinking. Again, they will challenge you with unexpected situations, and they expect you to show that you can adjust to certain situation, you can make judgment. What is ideal for 20 years old patients is not ideal for a patient with 90 years. So they expect you to be very flexible, to show that you have high order thinking and judgment. I think we will go through other lectures more detailed. This is just the first and general lectures, and we can go through some clinical scenario, but this is the very beginning. Thank you very much.